Hi, everyone. Welcome to today's webinar. Today's session is the next installment in the hands-on tips to improve diabetes care webinar series. Today, we're going to be talking about type 1 diabetes and eating disorders. We're glad you've joined us. I am Aaron Sutton, and I'll be moderating today's webinar. To share a little bit about myself, I am a clinical social worker and an adjunct assistant clinical professor of family and community medicine at Sidney Kimmel Medical College at Thomas Jefferson University. I'm also the behavioral health faculty for the family medicine residency program there at Abington as well. Today, we're going to spend the next hour talking about diabetes and eating disorders. We'll spend the next hour together by following the agenda on the screen. We'll be using 3 interactive features during today's session. We'll use the chat box to send you important links throughout today's session, so please locate it on your control panel now and be sure to click on it when you see the notification pop up or when you're asked to use it. We'll also use Zoom polling, so be prepared to answer questions when they pop up on your screen. Finally, if you think of a question as our presenters are speaking, use the Q&A box on your control panel. There's no need to wait till the end. We'll address all the questions that have been submitted once we get to the Q&A session. Before we get to our presentation, I wanted to share a few announcements from the ADA. First, I'd like to invite you to be part of the 82nd Annual Scientific Sessions. The sessions will take place from June 3rd through the 7th in New Orleans, Louisiana, as well as online. If you want to register at the advanced rate, you'll need to do so by April the 21st. To learn more or register, visit the link in the chat box now. During today's presentation, we'll be talking a lot about diabetes and mental health. The team at ADA wants to remind you of the various resources they've put together to help providers address the mental health side of diabetes. These resources include a mental health toolkit, including handouts and questionnaires, a diabetes and emotional health workbook, a video on-demand program that educates providers in diabetes and mental health, and a mental health provider directory. To connect with these resources, make sure to click the link that should be in the chat now. Now, I'd like to preview some other upcoming ADA webinars coming up. If you look on the screen, you'll see several upcoming webinars aimed at diabetes professionals. One I'd like to call special attention to is the Diabetes Technology Training Practices session happening later this afternoon. To learn more about or register for any of the webinars you see on your screen, including the session this afternoon, please visit the link that should be in your chat box now. Later in the hour, we'll share a direct link to register for our next hands-on webinar, which will be a session about obesity management in the primary care setting. Now, I'm about to give you a chance to use the Zoom polling system. We're going to see who all has joined us today. What role do you play in diabetes care? We want to know what role everyone here in attendance plays in diabetes care. There'll be a poll popping up on your screen soon. Please select the answer that most closely reflects your role in diabetes. You may have to scroll down to see your title listed. So here are our results. Wow, what a variety. I see diabetes educators, nutritionists and dietitians, physicians, advanced practice providers, and of course, behavioral health professionals, as well as physicians in another specialty, academic and researcher, and we have somebody from industry as well. So now that we know who all is with us, I would like to introduce the presenters for today's session. Dr. Claire Arneo-Peterson and Dr. Rhonda Merwin. Dr. Peterson is an associate professor in behavioral medicine and clinical psychology at Cincinnati Children's Hospital Medical Center. She is currently a clinical psychologist within the multidisciplinary eating disorders team. She specializes in the assessment and evidence-based treatment of eating disorders. Her research interests are many, but they include the treatment of eating disorders within the context of chronic illness, such as type 1 diabetes. Dr. Rhonda Merwin is a licensed psychologist and an associate professor in the Department of Psychiatry and Behavioral Sciences at Duke University Medical Center. Dr. Merwin is an eating disorder specialist who conducts research focused on identifying mechanisms of eating disorders and innovating treatments, generally and specifically in the context of type 1 diabetes. Dr. Merwin is recognized by the Association of Contextual Behavioral Science as an ACT trainer and is the director of the ACT at Duke Clinical and Training Program. She maintains a small clinical practice within the Duke Clinic that uses ACT to treat problems in living, including anxiety, mood, and eating disorders. Next, we'll address disclosures. Again, I am Aaron Sutton, and as it notes on the screen, I have no disclosures.
I'm Claire Arneo Peterson, and I have no disclosures to report.
I am Rhonda Merwin, and I also have no disclosures to report.
Thanks to you both. So, our learning objectives for today. So first, we're going to list the incidence and prevalence of disordered eating behaviors and eating disorders in people with type 1 diabetes. We're going to describe methods to identify common disordered eating behaviors and manifestations of eating disorders in people with diabetes. We'll also discuss evidence-based treatment options for disordered eating behaviors and eating disorders in people with diabetes. So I guess my first question really to Rhonda and Claire is, how common are eating disorders in type 1 diabetes? We're going to get a chance now to use our Zoom poll feature, and we're going to ask you to answer this question below. And now for our results. So about 20% of, 33% of people answered 20%. So, I'm curious, Claire, what do you think about that number there?
Yeah, so oh, and the poll results just popped up. But yeah, and the right answer is 20%. And actually, it's a little bit of a trick question because that is absolutely the most conservative estimate based on studies. So when we look at prevalence of eating disorders in individuals with type 1 diabetes, the studies, particularly with young women and girls, the studies range from 20% to as high as 40% even. And just to contrast this a little bit, when we think about the main eating disorders in the general population, anorexia nervosa, bulimia nervosa, binge eating disorder, and other specified feeding or eating disorders, and we combine all of those in the general population, they occur in about 10% of the population. So again, a more conservative estimate in the type 1 diabetes population, 20%. So just to kind of illustrate that they're highly prevalent in this population.
You can go ahead to the next slide there. I'm going to show you a graph. This is actually a Colton study, 2015. And you'll see that if you look in the literature, a lot of the studies are focused on young women and girls. It's not because it just occurs in female identifying persons, but it's because that's where you're going to see the vast majority. I think it's like a 10-to-1 ratio in the general population. For every 10 women that have an eating disorder, you have one man. And so it's not as common. Most literature is on young females. But I love this study because it's longitudinal. It looks at over time. And what they did was they followed young girls for 14 years. So this is beautiful, long time frame here. And they invited any adolescent girl that was coming through the clinic. This is a study that was out of Canada. And they invited any young women or woman with type 1 coming through there that was in the age range of 9 to 13 years, and they followed them. And what they found was that, so you can see that just as this tracks, I usually have I don't know, you can't see my pointer, can you? Can you see you can't see me pointing to this here. I usually like to sort of, point to what I'm referencing here, but you can see that that you have the black circles, right, are the eating disorder, folks with eating disorders, and the white circles are the disordered eating behavior. And this is cumulative probability sort of onset over time, right? So as you track these young girls over time, by time 7, so this is, they're in their early 20s or so, 32.4% of them have a diagnosable eating disorder. 8.5% have a subthreshold, right? So that is an incredible amount, right? We're getting into 40% or so of these young girls. Again, not selected for anything other than gender, that they were female and they had type 1 diabetes. And then if you look at the cumulative probability of onset, 60% by age 25. So by the time they're 25, 60% of them have had an eating disorder or subthreshold eating disorder of clinical significance. So this is pretty profound. Go ahead.
And we are really concerned with this population because for any of you that have worked with folks with type 1 who also have eating disorder symptoms, the outcomes are really, really severe. So this is another interesting study examining survival ratios for kind of three clusters. So individuals with type 1 diabetes only, individuals with anorexia nervosa only, and individuals with anorexia nervosa and type 1 diabetes. And I should mention anorexia nervosa has one of the highest, second only to opioid addiction, one of the highest mortality rates of any psychiatric condition. And so you can see even here again, the line for anorexia nervosa, survival goes down over time compared to folks with type 1 diabetes only. But perhaps even more staggering is when we look at this cohort of individuals with anorexia nervosa and type 1 diabetes, you can see just how sharply that trend is. And we see that rates, survival rates decrease more quickly. So not only suggesting that we have higher mortality rates in these individuals with both type 1 diabetes and anorexia, but the complications affect them and can even cost them their life much earlier.
So here we're just talking about premature mortality, but just to sort of highlight, if we don't have them on a slide here, but 3 times more likely to have early and severe diabetes related medical complications as well as premature death. This is 12 times more likely if you have the anorexia, but if you have the other variants, it's equally problematic and severe. So 3 times more likely to have early and severe diabetes related medical complications, more hospitalizations, more DKA episodes, et cetera, et cetera. We could just sort of go on with this litany of problems that emerge from disordered eating in this population.
Rhonda, we do have a question. So, with 20% prevalence, are you referring here to clinically diagnosed eating disorders?
With the what? I'm sorry.
With 20% prevalence. Are you referring to clinically diagnosed eating disorders?
Oh, go ahead, Claire.
I think from the first prevalence slide, yes. So clinical eating disorders. And then when Rhonda went over that slide, the Colton et al. Study too, they kind of differentiate again between, so those black circles would be a diagnosable clinical DSM-5 eating disorder, and with the white circles being more disordered eating behavior. And we're going to get into the nuances of that and why actually both are important, because folks engaging in disordered eating behavior, that is predictive of developing a clinical eating disorder over time.
Yeah, and there's also some data in the general population that subthreshold eating disorders or partial syndromes, or that sort of thing is just as devastating on people's lives.
Yeah. Thank you.
Mm-hmm.
So, how do eating disorders manifest? You were just talking about disordered eating and eating disorders. So how do they manifest in individuals with type 1 diabetes? And another question that came from the chat earlier is, why type 1 only as well? Why are we talking about that and not type 2?
So do you want to go ahead and advance to the next slide, and we'll sort of talk about the different clusters of behaviors that you see. So when we think about eating disorders, we think about dysregulated eating, and we think about maladaptive weight control strategies. Within the dysregulated eating realm, you have binge eating, and binge eating can be objective or subjective. So objective binge eating is feeling a loss of control in eating a large amount of food. A subjective binge experience, you feel this loss of control even if you're eating a small or normal amount of food. Subjective binge eating is just as important though, because it predicts maladaptive weight control strategies. So even if people are not eating large quantities of food, if they're feeling that loss of control during that eating episode, they're far more likely to purge in some way, either self-induced vomiting or omitting the insulin or omitting the insulin for that meal or whatever. So it becomes just as problematic. So you have binge eating, you then have extreme dietary restriction, and this can look lots of different ways. It can be restricting the overall amount of foods, the number of calories per day. It could be completely extracting macronutrients out of one's diet. So, pulling out whole, food types and things like that. Like rigid dietary rules is really what we're looking at, or what we're thinking of when we're thinking about extreme dietary restriction. It can also look like fasting. So just going without food for long periods of time. The other thing to say about it's in parentheses there below, attempting to follow strict dietary rules. So it's just as problematic if people are trying to follow these rules, even if they're not successful, because that sets people up actually to binge eat. So if they have this rule, like I can't have any cookies, no cookies ever, cookies are off limits. Even if they're not able to restrain from cookies and they have some, they're more likely then to binge on that because they have this rule that they're not supposed to have those. So once they break that rule, it's hard to then restrain eating. So extreme dietary restriction can actually be restriction, or it can be trying to restrict. And then people also sometimes vacillate between the two. This is actually super common, to go between binge eating and then, trying to rein and over control, and then, discontrol, and sort of back and forth between those two things. There's other strategies though that people might use other than restriction to try to control weight. And that's when we're getting into purging behavior, compulsive exercise, laxatives, diuretics, et cetera. And then of course, in this population, we're really concerned with the withholding of insulin. So either completely restricting insulin, or underdosing, or there's a whole range of ways that this can sort of look, but an effort to control or manage weight. And you see we can go on about what is binge eating disorder versus bulimia nervosa versus anorexia nervosa. I mean, it's just basically these behaviors can cluster in different ways, and then we'll call them different syndromes based on how they kind of cluster. There was a question in the chat too, I think, Aaron, what was it? Oh, why just type 1? Mm-hmm. That was the question. Yes. Do you want to answer, Claire? You look like you started to say.
Yeah, no. And I think Ronna and I kind of, when we were talking about this, I know our areas of research have focused primarily on type 1 diabetes. So I think that's why we're providing that information mostly to you today. But it's an excellent question. And we certainly, I've seen clinically folks with type 2 diabetes and co-occurring binge eating disorder. That's the most common sort of cluster that I have seen in my practice. So it's certainly not to say that those type 2 folks are not sometimes falling into some of these types of disordered eating behaviors.
I think what you see the most is you see nocturnal eating. This is what the literature would say, nocturnal eating and binge eating disorder in that population. The rates are far, like as far as the prevalence rates and estimates, they're far smaller. Like one study, it was 1 to 8% of type 2 patients had disordered eating behavior that was at a diagnosable sort of threshold. So it's not quite as prevalent, or doesn't seem to be. And it also might be that it comes in a different order, where for some folks, binge eating disorder might put them at risk for type 2 diabetes, as opposed to sort of the reverse, which is what you see a lot in type 1, where type 1 comes first and then an eating disorder sort of develops over time.
What factors, when we're talking about this, what factors could contribute to the development of an eating disorder in type 1 diabetes?
Yeah, it's a great question. And I'll just jump into that next slide to talk through this a little bit. When we think about individuals with type 1 diabetes, there are a lot of factors related to sort of onset of the illness the treatment regimen that can potentially exacerbate other risk factors for eating disorders. So for example, there's typically weight loss associated, as most of you know, prior to initial diagnosis of type 1 diabetes. And that can be particularly reinforcing, especially when we think about for young women and girls, and boys too, to some degree, boys and men too, but especially for girls and young women, there's this sort of normative discontent in our society for girls and women to be thin and to be sort of dissatisfied with their bodies. So having that weight loss can be really reinforcing. And upon diagnosis and they're starting their insulin regimen, that's associated with some rebound weight gain. And again, that's going to be distressing for a lot of folks, particularly girls and women, and can promote body image dissatisfaction. And this is true in the general population, but also in folks with type 1 diabetes, that body image dissatisfaction can promote disordered eating behavior through a multitude of pathways. By the way, this is not comprehensive. This is not every single risk factor ever, but dietary restraint, and Rhonda touched on this quite a bit, that when folks are dissatisfied with their bodies, they go on diets, right? And diets are prevalent everywhere, whether that's very low carb diets like the keto diets and things like that. But again, just this effort at restraint, meaning they're attempting to restrict their intake, whether they're successful or not, that's important, because like she said, if they have these dietary rules, most people can't sustain that. And that's why diets don't work, right? So they break the rule. There's this sort of all or none thinking, oh gosh, I'm off my diet now, whatever. And that can sort of set one up for binge eating, and then potentially other forms of disordered eating behavior like insulin misuse, purging, and so forth. And other pathways, there's sort of this pathway through feeling more depressed, and depression can be one way, sort of negative affect can be one way. Folks might binge to alleviate some of that night. So if I binge, it sort of helps distract from my negative mood. I feel better, I'm reinforced, I'm more likely to do it again in the future. So that's another pathway. And as we know, folks with type 1 diabetes are at an increased risk for depression anyway, right? So sort of a unique factor there. And then I have this separate kind of pathway through hunger and satiety disruption. So in folks with type 1 diabetes, they have some, depending on blood glucose variations, disruptions to amylin, they may have hunger and satiety disruptions that could directly promote things like dysregulated eating, which can then, I feel guilty, I engaged in binge eating, and then possibly efforts at purging, whether that's vomiting, whether it's insulin misuse. So a few factors associated with disordered eating, and I think Rhonda's going to talk about some other risk factors as well.
Yeah, I'm just going to expand just a little bit. So we both are sort of working simultaneously in this area and kind of thinking about it through different lens, through a slightly different lens, although not incompatible, and certainly can nice synergy and synthesis here. But the pieces that I want to highlight from our work or from our thinking on it is we focused a lot on perfectionism as a temperament or a vulnerability factor within the eating disorder literature more broadly, like outside of diabetes. This is a factor that seems to increase risk of eating disorders. Negative perfectionism in particular. So this is like fear of failure, of making mistakes. And what we have spent a lot of time thinking about is how that then, creates, or increases emotional distress around diabetes, eating, or weight. This sort of feeling of, not good enough, right? Nothing's ever sort of good enough, whether it's blood glucose control, whether it's controlling my eating for my diabetes or controlling my eating for my weight, et cetera, et cetera. So this sort of sense of not being good enough. And what we focus on is sort of these are functional pathways, really. So the functional significance of the symptoms, right? So all of these different strategies that are kind of, down here on the side, following strict dietary rules or overeating on highly palatable foods or withholding insulin, those are all sort of ways manage negative affect, or how I sort of feel about myself, my diabetes, my eating and weight, to sort of feel better, right? So there's functional, it's about, from our perspective, sort of avoidance and control of those distressing thoughts and feelings. And, some short-term relief when someone, withholds their insulin or binge eats or whatever, there's some short-term relief there for sure. And it's powerful and it motivates the action again, as Claire mentioned. But of course, it also maintains the problem, right? Because if blood glucose remains erratic or high, more feelings of failure and fear and distress, and potentially some blood glucose driven disruptions in mood, cognition, things that that would interfere with the ability to regulate one's emotional and behavioral responses. So then sort of just feeding into it. So this is kind of this is like functional pathways with a focus on kind of the vulnerability factor that might set someone up. So lots of different ways to think about it, and lots of different pieces that kind of come into play. It's a complicated problem in a lot of ways.
It certainly sounds like it. What are the signs that we're looking for of an eating disorder in somebody who has type 1 diabetes? How can we detect some of these eating disorders that we're talking about?
Yeah, and I think we have these listed as well on the next slide. So poor glycemic control, and actually this was something Rhonda and I were just talking about earlier, was, it's oftentimes like a telltale sign is seeing some really erratic patterns. And we could go into, I could have a whole talk probably based on that and sort of different profiles. But when you're seeing sort of some erratic differences with glycemic control, overall having really poor control. We know that obviously that could be a number of things, not just an eating disorder, but certainly can be a sign of one. When individuals are expressing difficulties controlling eating or weight, certainly weight gain. We know that weight gain can be a big trigger for that as well. For, again, that sort of body image dissatisfaction. It's a really potent risk factor for eating disorders. And so will maybe motivate someone to try to lose weight. Folks that are really distressed with weighing, they don't like to see their weight. They don't like to talk about their weight. Certainly if you're noticing any changes in growth curve, so whether it's really steep, sort of quick changes, whenever you see someone kind of jumping through lines on a growth chart, that's concerning, or even something that's kind of more progressive over time, or maybe someone's kind of fallen off their curve on the more ANs, the more anorexia side. So, and also just, I think we have a couple of tips here too, with signs. I think, trying to differentiate and ask questions too, like not because, it could, someone with this problem could be presenting very similar to someone who is generally non-adherent, right? And sort of how do you sort of tease apart those differences and knowing the right questions to ask. And so if you're starting to see some of these red flags, being able, and we'll talk a little bit more about this, how to like sort of create that environment, cultivate that environment.
Yeah, and the one thing that I just sort of jump in here and just say is, like, I almost think about it like having just your ears perked, right? To sort of in the encounter with the patient, no matter what you're talking about, does this person seem to be sort of focused on weight? Do they make some comments about having difficulty sort of controlling their eating, right? Are they sort of saying, oh gosh, it's just really hard for me to stop once I've started? Do you see them look visibly distressed in some way after they weigh, or are they making like comments the whole time, like in the encounter about their weight, right? And, not that these are going to be like, oh yes, this person definitely has an eating disorder, but that's sort of listening with that ear, kind of noticing if there seems to be some, clustering, a few of these sort of show up in some of the encounters, I'd be really concerned.
And changes in eating patterns too. And sometimes I think initially, and I'm coming from more of a child adolescent lens, but I think true for adults too. If, sometimes I'll have families and parents that will say, she kind of is going through a health kick right now and has started eliminating, junk foods from her diet. And that can sound fairly innocuous, but it's also just important in this population, knowing that they're at a greater risk of developing an eating disorder, that can actually be a potential risk factor. So.
Yeah, and I saw a little question come up in the chat there that actually is our next thing. And those two points that were on the bottom of that last slide were, ask, right? Because sometimes we don't ask because we sort of don't want to know, as a psychologist, sometimes, you don't want to ask certain questions, about self-harm or other things, right? Because then we have to sort of, there's a whole series of things that get set in motion, but ask. And then the other thing is assessing routinely. And that's where we're sort of going next. If you ask at routine encounters, right? If people complete a quick little screen at routine visits, get really used to doing that, then that would be a way to identify or detect some things that might not come out, in the verbal face-to-face encounter. So the surveys that we have up here, there's lots of other ones that we can certainly point you guys to, but the diabetes eating problem survey is one that's very commonly used. It's actually 16 items, and there's not really a screener that's shorter. But in our work, we found that these 2 items, if you ask somebody about whether they feel their eating is out of control, and you ask them if they take less insulin than they need because of concerns about their eating and weight, then you're going to capture you're going to find most people that would then elevate the full scale. So, some people will endorse one of those and not the other. Some would endorse both. So we've used these 2 items as a screen. That second item is adapted slightly because the DEPS actually has a more direct question about less insulin for weight loss, but some people have concerns about whether that informs people about this strategy. So that item's a little bit kind of tailored to address that concern within the Department of Endocrinology, because we've asked endocrinology to do this on the regular. The one below that, the diabetes distress scale, this is a 2-item screener that's used, but there's a whole scale, and there's one for type 2 and one for type 1. But this is just asking people if they feel overwhelmed by the demands of diabetes or like they're failing at their diabetes routine. Now, obviously, you're going to have people that will elevate that do not have an eating disorder. But what we found is people that are slow to disclose an eating disorder or have a lot more shame or secrecy around that will be willing to disclose distress about their diabetes. And if they're distressed at a particular level, they probably are having trouble managing their eating or their insulin, and they probably need some psychosocial intervention anyway. So you want to find them anyway. But we've also used the diabetes distress scale as sort of another way to identify people that may need help in this area, and to then ask some follow-up questions. So that's another screener that might be used. And I do think that both of those are recommended, at routine visits now, sort of broadly. To be asking about diabetes distress, to be asking about eating disorders. That's all I have there.
So what type of treatments, Rhonda, is available for people with eating disorders that have, type 1 diabetes?
So this is a multi-point question here, because there's, we have our adolescent. We're actually not going to go to this tailored interventions quite yet. We're going to talk a little bit about the adolescents first, and then the adults. So I'm going to pass the baton to Claire because she does the adolescent work.
Yeah, and the answer, the short answer is no, not yet. So I should mention, in the adolescent world, for eating disorders in the general population, family-based treatment, or the Maudsley model, Maudsley method, is the evidence-based treatment for anorexia nervosa. That treatment has also been tested in adolescents with bulimia nervosa. To date, there have not been any studies augmenting or sort of modifying this intervention specifically for youth with type 1 diabetes. The adult world, there's a little bit more, and Rhonda will talk about that. But what I will just give a quick plug in terms of clinical care, because I see these patients, and I do think there is a nice parallel between what we might do, and I'll speak to this a little bit in one of the case examples I go over, but I think family-based treatment for anorexia, there can be some really nice parallels with what we might do with a kid that's really struggling, a teen that's really struggling with diabetes and self-management too. So in terms of really working, with parents, but having this be something that, is titrated developmentally, because eventually we want the adolescent to be able to manage their diabetes, more independently. Similarly with family-based treatment for anorexia, in the beginning, parents are managing a lot more, portioning food, feeding their kids. And then over time, parents are, as the kid is eating and improving, parents are stepping back a little bit more. So I think there's some nice parallels, and there, the study needs to be done. The research needs to be done there. But so again, I think that's something that in my clinical practice, and I know for a lot of us here with our adolescents, that's typically what we do. But again, from an empirical standpoint, it has not been tested. And Rhonda will talk about the adult world, where we have a little bit more research.
Yeah, well, a little bit more.
A little bit more.
Yeah. I mean, well, and there are evidence-based treatments for eating disorders. It's just that the modifications for individuals with type 1, that's where there's a dearth of research and sort of more that needs to be done. So we certainly can address eating disorders in individuals with type 1, modifying our evidence-based treatments like Claire was talking about with family-based therapy, but also there are certain things, certain interventions that you would do with someone with an eating disorder, whether or not they have type 1, so you'd want to have a multidisciplinary team, right? You'd want to work on eating consistently throughout the day, either with parental assistance or without, and working on permission, right? No foods off limits to disrupt that binge eating cycle often. And you'd want to work on people attuning to their hunger and satiety cues kind of over time. And, and I get that it becomes really all of those things, right? As you can hear, as I'm saying, them become really complicated when type 1 is in there. You really got to be thoughtful about those things. And we could kind of go on about some of the particular interventions in evidence-based treatments for eating disorders and really talk through how we would modify them clinically. But in terms of like what's out in the literature, you're not gonna find as much. So the things that we do that there is literature on for eating disorders and type 1, there are studies that show that residential and inpatient treatment, where they have a specialized diabetes track, or they're specialized for eating disorders in type 1 diabetes. Those programs can improve HbA1c. The thing is, though, in an inpatient residential facility, right, somebody else is taking some bit of control, right? There's a container there, there's set meal times, somebody's monitoring the insulin, et cetera, et cetera. And so we don't know what happens to folks when they leave inpatient or sort of a residential, treatment setting. So we don't know if the gains are the improvements are maintained. So that's a big problem there. They're also rare. There's not that many programs. There's probably 6 or something in the US. They're expensive, that kind of stuff. The other thing that has been looked at is there've been a couple of outpatient studies that have looked at, how do type 1 patients fare in conventional eating disorder treatments? Do they do as well as their non-diabetic counterparts? And they don't seem to fare as well in those interventions. Sometimes what you see is improvement in eating disorder attitudes, but no change in glycemic or metabolic control. So there's that bit of literature that's kind of out there. What we've been talking and thinking a lot about, I think people that are working at this intersection is, we need to get the studies done where we're tailoring interventions, right? And that's the next, this is just a very, it's an open trial, so there's no comparison group. This is very like early work. But what we were trying to do was take acceptance and commitment therapy, which is contemporary cognitive behavioral therapy, and adapt it for folks with type 1 diabetes and eating disorders. So these are adult women, mostly with bulimia nervosa or that spectrum, a few with binge eating disorder, and a few with purging disorder, where they were omitting their insulin but not necessarily binge eating. Most of the people that did this study completed the treatment, which is a big deal in eating disorders because people drop out. And so that was really positive. It was 87%. So significant amount completed it. And we did see some really large effects for decreased in eating disorder symptoms, improvements in management, and decrease in diabetes distress. HbA1c also improved a percent, like 1% about, and some of those folks had a lot further to go, but you don't want to go too fast anyways. And this was over, and that's still a clinically significant change. And this is over a 3-month period. So, this is what it was a 3-month intervention. So pre-post kind of thing. So, it just suggests that tailoring interventions can work, and we need to compare it to another active condition or weight loss control or something to show that it's better than what's out there, or to tailor it is better, not necessarily this particular intervention that we did, but I think tailoring is important. All right, we'll move on from there.
Yeah, and again, we do have evidence-based treatment. So for switching to adolescents, we do have evidence-based treatment for eating disorders in adolescents. And again, the idea is, I think a push to modify these interventions specifically for this population. So just to illustrate some of the, also just some of the risk factors that we discussed. This is a 15-year-old male case example. So this is someone who historically was quite overweight in the obese category. Type 1 diabetes was diagnosed. Oh, my little highlights. Oh, there they are. They are there. Okay, so without having a little pointer, but the the lowest data point on this person's growth curve is when they were diagnosed with type 1. And thank you. And then it's a little bit hard to tell, but they kind of gained back up. Not quite little. Anyway, they gained weight again, all the way like from that point up to about 215 pounds. So off their growth curve. And that was really distressing to him. He had a lot of weight concerns. And so the second highlighted point is the drop. So he dropped weight all the way down from up. He was off his growth curve down to, I guess, about the 85th or so, maybe, yeah, 85th. And so this was primarily done through sort of a combination of restricting. He was on a keto diet. So during the day would restrict really heavily, eat very, very few foods, actually would skip breakfast, eat a very small lunch, very small dinner, and then binge at night and omit insulin. And that's how he achieved such a weight loss. And then the very last highlighted point was him actually decreasing his eating disorder behaviors. And that led to some weight gain. So, and you can see, and also that last highlighted point was the point at which he dropped out of treatment. I feel like normally in case studies we're supposed to highlight a successful case. This was not a successful case. This is someone who dropped out of treatment. And then you can see he fell right back off his growth curve. So likely, I don't know, because I was not, continuing to work with them, but lost significant amount of weight through likely this cycle of restriction and insulin misuse. And in terms of risk factors, this person was more of had more impulsivity kind of personality profile, very distressed about that weight gain. The weight gain was a big risk factor. The depression was a big risk factor. Then not even just depression, but more momentary, just kind of little things would upset him. He'd get really distressed. And then binging was a way that he kind of coped with that distress. So, but then again, would feel really guilty for binging and then omit insulin. And not surprisingly, this person had a really high rate of healthcare utilization, ED visits, DKA, hospitalizations. A little bit of a different presentation with this person. So this is a young adult, we'll call her Emma, so 24 years old, female, non-Hispanic white, historically was a normal weight, and then began gaining weight after the type 1 diagnosis. So again, had a lot of distress about that weight gain, developed a lot of body image concerns, And she kind of developed this pattern where she also would restrict during the day. Are we answering the questions now? Because this is such a good question.
I thought, please, Claire. So, would you consider gastric bypass surgery? I didn't see I knew the question was, I didn't see the end. After failure in counseling, is that something you would consider, gastric bypass surgery?
As an eating disorder therapist, I would not know, but again, it's just not an evidence-based treatment for an eating disorder. I think there are other reasons that people pursue that type of treatment. One of the things that Miguel, I'm thinking they're referring to Miguel on the previous slide, even though they were able to really work on improving their insulin misuse, I really could not get him to eat regularly through the day. So he was still having dysregulated eating at night, which likely was why he was gaining weight. I could not get him to understand that if you could eat, regular meals and snacks throughout the day, have more regulated blood sugar throughout the day, it actually will help you not binge and probably help you a little bit more in the weight department. But again, as an eating disorder therapist, I'm not going to focus on weight because and we'll talk about the reasons why, but there are many that typically backfires if we kind of have this over focus on weight. But anyway, so this person, so gaining weight after the diagnosis. So again, weight gain was big, right? A big risk factor, promoted body image concerns. And again, this cycle of, I'm distressed, I don't like my body, I want to restrict, develop strict dietary rules, and then would binge at night. This person was not misusing insulin, was not purging in any other way, and has continued to gain weight, has more of a binge eating disorder symptom presentation.
And then if you want to, go ahead and go to the next slide. So you're going to be like, whoa, look at all those words. I'm not actually going to go through all these folks, but this was me like thinking, okay, who will I present? And I had all of these are all young women. Well, not all young women, right? We have, I tried to get a little diversity in age. So I included a 60-year-old patient that I had, for example, and some of these are in their later 30s, and then some younger folks in 19, 21 and 24. So I tried to sort of give a mix, but when I was thinking like, who am I going to present? I couldn't hone in on one case. And there's so much richness in their stories and so much they share some things, right? But there's places where their stories become very, very unique. And so I, part of like putting it and letting it be these tiny little letters was to highlight, like, we really do have so many more people that are suffering and that all have unique stories, in terms of how they sort of find themselves in this place. All of these folks, I mean, again, I'm thinking about it from a functional lens. I was thinking about, the ways in which the eating disorder was helping them feel better about themselves or their situation, feel like they had some degree of control or could manage some really difficult feelings that they were experiencing for a variety of reasons. And there were different patterns. I tried to include some information on A1C when I had it, just to sort of show you that, some of these folks were definitely topping over 14. I had other people that were in this like 8 to 9 range. And their presentations are different. We could spend I'm trying to not get pulled in and start talking about all their individual stories because it will take the rest of our time. But I just want you to sort of notice how there is some variability there. The A1C is kind of on the end, and I included someone in there that has more that anorectic pattern where they actually have sometimes these really like low A1Cs, right? But they are emaciated and they're suffering, but they may not be even sort of noticed because their A1Cs are, they're in good control, but often having like frequent hypoglycemia and other kinds of problems. And I was thinking of two different people there, both started with the letter K, who are really undernourished and really, suffering. But anyways, we can come back to this if we have more time to talk about cases, but I want to make sure that we have time to go through the tips. And so if people want to talk cases, we can sort of loop back. And I'm not going to go over this other than to say that sometimes just looking at the A1C, right, you saw that the first several cases that I listed were definitely popping up really high on A1C and would be flagged by any provider as having issues. But we also saw this a lot in our studies. So this is three days of continuous glucose monitoring with one of our participants. And what we've done on the bottom here is just kind of marked, because they were doing diary palm, kind of like Palm Pilot sort of diary. That's the old language. They were using an app basically, but putting in some of this information on, what was going on with them behaviorally or emotionally and behaviorally, and we time synced it with their CGM data. And so what you can see there on the bottom is how, they feel like they lost control over eating, but ate a normal amount. So they sort of partially omit their insulin and their blood sugar climbs. And then as it starts to come down again, then they have a full, they have a binge and full emission of insulin, and it just kind of keeps sort of riding up. At least that was their report that coincided with their CGM. And so sometimes you see these roller coaster kinds of things where overall, I didn't pull what this person's A1C was, but we had people that would, roller coaster like this. So they might not, show up as being extraordinarily, extraordinarily poor control unless you're looking at their CGM and seeing some of this roller coastering and stuff. With it being an average, you just lose so much information. So I put that up as an illustration of that. So practical tips. We need to get to this before we run out of time. What are your practical tips? All right. So do you want to go ahead and take this one, Claire?
Yeah, absolutely. So I think we've alluded to this tip. All these tips should hopefully sound familiar, but avoiding rigid diets or dietary rules. And this kind of goes back to the gastric bypass question. When you think about, that is like the ultimate rigid diet that I can think of, because I think you're on liquids or something, or purees or something insane like right after. So so avoiding rigid diets or dietary rules. I think along with this, a dietitian as part of that multidisciplinary, interdisciplinary team that has some eating disorder expertise, because I think the language spoken in eating disorder treatment is more all foods in moderation, as opposed to characterizing foods as good or bad, or sort of like the red light, yellow light, or green light, those types of models where it's insinuated then this is a bad food or this food is unhealthy. And so really avoiding that type of language with patients.
And this sort of follows from that a little bit, but overall avoiding good, bad, or evaluative language. So not labeling foods as good or bad, blood sugars as good or bad, A1C is good or bad. I appreciate that an A1C, like a real elevated A1C or blood sugars that are all over the place are problematic, but using more descriptive language and shifting away from things that have that kind of evaluative lens, because folks that are prone to eating disorder may be more tuned in and vigilant for signals that they're doing bad and wrong, or they need to do better. They fear of judgment and making mistakes, and those kinds of things are something that sometimes predisposes someone to an eating disorder. So being mindful around this language, because you want them to, at least with regards to the diabetes, the diabetes control kind of language, right? You want them to keep approaching diabetes and diabetes management, and it's going to be something that they avoid if it feels like it's sort of layered with kind of evaluative language. And not because like you guys, like any of us intends to use that language. It just, it's just easier and quick sometimes. And so trying to be really thoughtful and using descriptive language, treat rather than correct is another one of those little subtle ones, that people that are feeling like they may be doing bad and wrong might be sort of perked for that. I need to correct my blood sugar, right? Or I need to treat a hypoglycemia. It's experienced differently sometimes for these folks, and may be helpful in them approaching diabetes and diabetes management. And then the good, bad food sort of goes with what Claire was saying too.
So tip 3, setting realistic goals and celebrating successes. So we're not trying to set these monumental goals, but rather, kind of small steps for patients. Again, I think it sort of fits with this more sensitive temperament too, that that Rhonda was kind of alluding to in the previous tip, that it's just really important that we are celebrating those small goals and any movement in positive direction, and any changes in A1C, however small they might be.
I often drive this point home with patients by showing this graphic. And, like if, anywhere that you sort of track down on this curve, right, you're bringing your risk down. And this resonates with people. Like they can appreciate how important it is to come down, a half a point or a point, because you can sort of see visually how your risk for these various complications, decreases as a result. Oh, it went away. Avoid making weight loss a goal. Yeah, go ahead, Claire.
Yeah, so not emphasizing the weight as a goal. So again, thinking about health behaviors. So even in the case of someone who is maybe overweight or even obese, talking about making sustainable changes to health behaviors, as opposed to, we want you to lose 20 pounds and things. And I think there are a lot of folks that are moving in that direction anyway, but I think it cannot be emphasized enough that, this can create a lot of shame. It reminds me of those printouts that you get at your PCP that will be like red, caution, overweight, obese. And I mean, what does that do? It causes shame, right? And not necessarily motivation to change.
Yeah. The other thing that I often think about, or kind of pinging off of that, is like, if you're true to the process, the outcome takes care of itself, kind of thing, right? So if you're kind and responsive and take care of your body, right? So, eating and attending to, like, okay, I'm satiated, moving the body, doing those different things, and the outcome takes care of itself. Like weight will trickle down as you sort of respect your body and your body's signals and needs and stuff. And then the last tip is cultivating a safe space to disclose. This is so important. There's so much secrecy, guilt and shame around eating disorder behaviors. People often hide binge eating, for example. Sometimes they're very protective of their symptoms because they don't want to let go of this thing that has, that sort of promises to make them, to help them feel better in some way, even if it's short term. So creating a safe place where people can disclose these kinds of struggles. And where they can disclose difficult emotions, right? That diabetes is hard, or that they're that they're burnout and they really have just sort of stopped doing things. And diabetes burnout and diabetes distress do really, if you look at eating disorder literature, there is a high correlation between those two things. So where they can report difficult emotions either around diabetes, around eating, or around weight, or disclose behaviors that they might otherwise want to hide. And how do you cultivate a safe space? You probably pause, slow down, warmth, body language, trying to take out patients might say something that shocks you, right? Trying to sort of take out the shock a little bit, to convey just sort of openness and acceptance and that kind of thing. It can be hard sometimes when people say things that are really, they disclose a really scary behavior they're engaged in, or they say something that's really painful to hear, right? So, trying to be a space where that can be received and it can feel like it can, be received, I guess is the best way to say it. Do you have anything else to say about that, Claire? Because that one's so important.
It's so important. I think it does tie in with our bonus tip though, because I think this is where having that expertise is so important. If you have the diabetes piece, but you don't have the eating disorder expertise, you're missing a big piece of it. If you have the eating disorder expertise, but no diabetes, so it really, I think, is important. Again, in order to cultivate that environment, that you have someone that, if, first of all, is aware of this as a problem. And I think that sometimes is hard to come by. So I think we're providing a link maybe to some folks, a directory here.
Yeah, and I just want to highlight Laura's comment because I can see it there, and I think that's a great point.
Yes, the blind weights.
Yeah, the blind weights. Yeah, and sort of being really thoughtful about like knowing what a blind weight is, and being
Yeah.
thoughtful about not sort of then saying the weight out loud or putting it in the
Yeah.
chart, letting the parent sort of talk about it or whatever. Yeah.
And it's a great example of how we do that in an eating disorders. It's standard. In an eating disorders clinic, you get blind, you come in, you change into a gown, you get a blind weight, and that's just what's done. And so again, I think having that multidisciplinary approach where everyone's kind of speaking the same language is super important.
And there's lots of resources to be sort of had. So we put some of them on the slide here. Obviously the ADA, the College Diabetes Networks, Diabetes Sisters, if you're not familiar with them, they have pods, meetup groups, and various things, and lots of supportive stuff. And then the other two that are there, I just want to highlight the little asterisk. I'm mentioning that these are managed by individuals in eating disorder recovery because that's just important to know. You want to be mindful about who you send to these kinds of resources, and whether that will be problematic for them in any kind of way. But they do have a lot of really great resources, including like lists of providers that work at this intersection and things like that.
Claire, Rhonda, what a great presentation. For those who have not asked a question, we'll have time for maybe one question before we have to close. I know we're getting close to the 4 o'clock hour here. But before, I want to give you some quick announcements from the ADA. So first, join us please on Tuesday, May the 10th for a webinar on obesity management and primary care. The session will be presented by Dr. Summer Hafida and Dr. Rosalina McCoy. So please click the link in your chat box now to learn and register there. Finally, I want to remind you that you can rewatch any of these hands-on webinars dating back to September of 2020. You can even still claim CE credit for any webinars dating back to April of 2021. To do this, just access ADA's Professional Education Library by clicking the link in your chat box now. Now we'll have time for one question. So really, I think more of the comments. So, Rhonda, you and Claire both were talking about that, really the blind weight. And would that be your biggest take home point for those who, there's a lot of questions and statements about that in the chat box. Is that one of your biggest tips is talking about the blind weight there?
I mean, I think that goes along, I guess, to expand upon that de-emphasis on weight. I think those two go hand in hand. So blind weight is one way I think that can be accomplished. But even with something like binge eating disorder, so often, when that kind of hangs together with someone who is overweight, I think patients can get really hung up on, I need to lose weight, I need to lose weight. And that pressure, on the number and sort of the obsessive weighing can actually, it doesn't tend to be super helpful. Yeah, it's actually much more helpful if we focus on the behaviors. Let's get you eating breakfast. You're skipping breakfast. Skipping breakfast is one of the biggest predictors of someone being obese. They don't eat enough throughout the day, and so they're extra hungry, right? And then you think about that in the context of type 1, it can be even worse. So anyway,
yeah, and I would just sort of expand on that and with a couple other sort of pieces around. Like another example would be like if we can teach people to notice what they're actually feeling and respond to that feeling with the need that's being communicated, right? Like they may typically respond by reaching for food, right, and managing that emotion through food, for example, and teaching people to say, oh, actually I'm lonely, maybe I need to reach out to someone, or I'm feeling, whatever it is that I'm sort of feeling in this moment, whatever my emotion is, and being able to then reach out for the thing that they actually need. That those things will actually have more impact on weight over time than focusing narrowly on a weight goal and the need for weight loss, right? Sort of changing the patterns of how people respond to their cues and treat their bodies and that kind of thing,
And I should say this advice sometimes is at odds with, it's interesting that the next talk is on obesity and treating obesity in primary care, because I don't think those things should be opposing, but sometimes I think there can be opposing messages, but that's another talk.
Great. Again, thank you, Rhonda, Claire. Great job. Before we end today's session, I wanted to let you know what to expect from this point. So later today, you'll receive a post-test by email. Please complete it so you can claim CE credit. For those of you who may be interested in starting the CE process now, we've included a link to the post-course items in the chat. It's the same information that you'll receive via email today. If there are any questions we didn't get to during the webinar, we'll be following up via email with those of you who asked them. I want to say thanks again to Dr. Arnio Peterson and Dr. Merwin for sharing their expertise with us today. I also want to thank each of you for joining us. We hope to see you at another ADA webinar in the future. This concludes our session. Have a great afternoon.
Thank you.
Thank you.